Hi, my name is Erin Evans, and I'm going to talk briefly about initiating a non-invasive respiratory support protocol following delivery of infants less than 30 weeks gestation. The idea behind the Quality Improvement Protocol came from the Committee on Fetus and Newborn. The committee released a policy statement on respiratory management following the delivery of extremely premature infants. After reviewing multiple studies, the committee determined that infants managed with non-invasive respiratory support with rescue or selective surfactant treatment resulted in fewer incidences of BPD or death as compared to historic practices of intubation and surfactant administration. Respiratory distress syndrome, or RDS, is a disease primarily of prematurity. It begins at time of birth and increases in severity over the following days. Surfactant deficiency has been recognized as the primary cause of RDS. Surfactant administration has become the gold standard for treatment of RDS in premature infants. The Quality Improvement Project was implemented in a 35-bed Level III NICU that practiced intubation and surfactant administration at time of delivery for most infants less than 30 weeks gestation. With this system in place, it can take up to 24 to 48 hours to extubate an infant for the first time. Considering that blood gases are followed every 6 hours in stable infants, and these infants are usually started on rates of 40 to 45, if blood gases are stable, the infant is weaned by a rate of 5 to 10 every 6 hours, accounting for the time frame. This can prolong mechanical ventilation on infants that don't need it. The literature review provided the foundations for this quality improvement project. The literature revealed that infants as young as 24 weeks can be successfully managed with non-invasive respiratory support following delivery and can have similar or improved outcomes when compared to intubation with prophylactic surfactant administration. Between the months of January 2014 to April 2014, there were 10 infants born at Integris Medical Center between 27 to 30 weeks gestation. Of these 10 infants, 4 were intubated at delivery, 5 received surfactant therapy, 0 were on oxygen at 36 weeks, with 1 death. The death was neck-related. The average gestational age was 29 weeks gestation, the average birth weight was 13-16 grams, and the average number of days on mechanical ventilation was 1.8 days. The PICO format was used to develop the clinical question. In infants between 27 to 30.6 weeks gestation delivered at Integris Baptist Medical Center, does initial management with non-invasive respiratory support and treatment with selective surfactant, as compared with historical practice of intubation and surfactant in the delivery room, decrease the number of delivery room intubations, decrease the number of mechanical ventilation days, and decrease the incidence of death or BPD. The Planned Use Study Act is the quality improvement model utilized to implement this quality improvement project. All infants between 27 to 30.6 weeks gestation will be involved in the project. Exclusions include significant facial anomalies, airway obstructions such as TE fistula, tracheal malacia, choanal atresia, congenital diaphragmatic hernia, known genetic disorders, and potentially life-threatening disorders unrelated to prematurity, with the main premise of the project changing the initial respiratory management of these infants in the delivery room. The project began at time of birth. Infants who did not have spontaneous respiratory effort in the delivery room were treated with the historic practice, and infants with spontaneous respiratory effort were managed with non-invasive respiratory support protocol. Both cases of infants were included in the data collection. The practice change utilized a flowchart that I developed after reviewing literature and placed the current standard of practice in the delivery room for initial respiratory management of infants 27 to 30 weeks gestation. The flowchart was followed for the first 24 to 48 hours of age, and then infants were managed according to their clinical status. 2 different flowcharts were developed for this QI project. The first was a flowchart to be utilized in the delivery room and provided a visual reminder of practice guidelines for physicians and NMPs immediately following delivery. The second flowchart developed was placed at the infant's bedside at time of admission and remained there for a minimum of 48 hours. It provided a visual reference for nursing staff and respiratory therapists. All infants born between 27 to 30 weeks gestation were included in data collection. The practice was initiated at time of birth. Infants with spontaneous respiratory effort were managed with the non-invasive respiratory support protocol, and infants with respiratory depression were managed with historic practice, with the goal of extubating as early as possible. Logs were placed in each patient's chart to allow for easy data collection. Logs remained in patient's chart until time of discharge. The project was implemented on January 1, 2015 and continued through April 30, 2015. Within this time frame, there were 14 infants born meeting inclusion criteria. Of these 14, 7 were intubated at delivery, 10 received surfactant, 5 were on O2 at 36 weeks. There were no deaths. The average gestational age was 28.5 weeks gestation. The average birth weight was 1088 grams, and the average number of days on mechanical ventilation was 10.7 days. Data was analyzed by completing a retrospective comparison of infants of similar gestational ages. SPSS was utilized to analyze historic and new data. Pearson correlation coefficient was calculated between participants' days on mechanical ventilation and need for oxygen at 36 weeks. In the historic group, there was a weak correlation that was not significant, indicating that increased mechanical ventilation days do not affect the need for oxygen at 36 weeks gestation. But in the group managed with the new protocol, there was a strong significant correlation, indicating infants with a greater number of mechanical ventilation days have an increased need for oxygen at 36 weeks gestation. This QI project did not answer the question, does initial management with non-invasive respiratory support and treatment with early selective surfactant, as compared with historical practice of intubation and surfactant in the delivery room, decrease the number of delivery room intubations, decrease the number of mechanical ventilation days, and decrease the incidence of death or BPD. I believe this is due to the fact that the QI group of infants was smaller in birth weight and had a lower average gestational age, although this is difficult to prove and is just an assumption. A scatter plot graph has been developed revealing days on mechanical ventilation and length of stay in infants managed with non-invasive respiratory support or intubation at delivery. Scatter plots were developed for historic group and QI group infants. Scatter plot graphs do reveal that delivery room intubations result in an increased length of stay. Although the outcomes of the QI project were not as expected, they were deemed positive and the new practice will continue to be followed. The project will be sustained by continued involvement of identified nurse and respiratory therapy champions. The outcome data has been shared with the staff. The use of nursing staff and respiratory therapists throughout the project has resulted in mutual ownership that has led to increased compliance with the new protocol. Although outcomes of this project change were not as expected, it has resulted in a culture change throughout the unit. Implementation of this quality improvement project has resulted in not only a practice change, but also a culture change. Infants are no longer automatically intubated and given surfactant based on gestational age less than 30 weeks. Each infant is assessed at the time of birth and respiratory support individualized to the patient's needs. This individualization of respiratory management at delivery has resulted in a culture change within the unit. Decisions are focused on infants' individual needs and not gestational age expectations. Initial noncompliance with the practice change has been eliminated and staff compliant with the new practice. The unit and patients have both benefited from the change. As a result of the practice change, it is still necessary to follow the outcomes of infants treated and continue to expand to all gestational ages.